anastomosis that I said, these babies transfuse blood back and forth. It keeps happening invariably in all monochorionic pregnancies. And in 85% of these identical twins, the monochorionic placentae, this transfusion is balanced out, either by the number of AVs being equal in both directions, or because if there is an imbalance, there are enough number of artery-to-artery anastomosis that balance it out. So 85% of all monochorionic pregnancies, the transfusion that happens back and forth is fairly balanced. And therefore, you do not have complications related to twin-twin transfusion. In the other 15%, there is an unequal transfusion. And this net transfusion happens because either the numbers don't agree, or the types are discordant, types of anastomosis are discordant, or because the sizes of anastomosis are discordant. So the net transfusion that happens between the two twins could be dictated by the number of vessels, the type of anastomotic vessels, and the size or caliber of these anastomotic vessels. And it is a net result of all of these that decides which way blood goes, and which way more blood goes, and which way less blood goes as well. For example, if you have 3 artery to vein connections, as I said, in an AV connection, blood only flows from the artery to the vein. So if you have 3 connections from B to A, and only 2 AV connections from A to B, you would expect that over a period of time, B sends out more blood to A than it can get back. So eventually, as time progresses, B loses blood, A gains blood, and therefore, there is a kind of a twin-to-twin transfusion syndrome that's going to develop in these twins. But however, having said that, if you have enough number of AAs within the placenta, as I told you earlier, they will play the liberant role, they'll play the balancing out role. And to a large extent, they will offset this imbalance in the discordance in the number of AV anastomosis that are there. So even if it is 3 to the side and 3 to that side, or if it's 3 to the side and 2 to that side, if you have enough number of AA anastomosis, they can balance out that difference and make sure that these twins do not get into trouble. On the other hand, if you do not have these protective artery-to-artery anastomosis, or they're very few and far between, is when there's going to be a net transfusion from twin B to twin A, and that is what can result in an unbalanced vascular scenario, and this leads to the named syndromes of TTTS and TAPS, or twin anemia polycythemia sequence. Now, the difference between TTTS and TAPS is in the size or caliber of the vessels. Remember, I told you it's 3 things that decide the net transfusion: the nature of the vessel or the type of the vessel, the size of the vessel, and the number of vessels. So in TTTS and TAPS, it's basically different in terms of the size of the vessels that are involved. In TTTS, it's large AV connections that are at fault, whereas in TAPS, it's tiny peripheral connections that are at fault. The difference being, when there are large unbalanced connections, there's a large volume of blood that transfers at one point from twin A to twin B. And this triggers certain endocrine responses, like ANP gets secreted on one side, and you have renin-angiotensin mechanism on the other side being activated. And that's what leads to the cycle of oligo and poly. Whereas when you have tiny unbalanced AVs, the leak that happens from one side to the other is very little. And therefore, the babies get time to adapt much better. And therefore, the endocrine response is not stimulated. Rather, what you would have is just a difference in hemoglobin because of the chronic leak that happens. So that's the basic difference between TTTS and TAPS in terms of the size or caliber of the vessels that are involved. Both are abnormal AV connections or unbalanced AV connections. It's only the size that decides whether you develop TTTS or TAPS in that particular set of twins. Now, I kept harping about the fact that AAAs or AAAs are all protective, or artery-to-artery anastomosis are protective, but not all of them are. For example, if you have an artery-to-artery anastomosis in the setting of a very peculiar angioarchitecture of the placenta, where you have the artery-to-artery anastomosis that is often paired with a vein-to-vein anastomosis, you have the 2 cord insertions very close to each other, within 15 centimeters of each other. And more often than not, you have 3 vessel cord on one side and a single umbilical artery on the other side. And this is the substrate that is there. And for some reason, very early on in pregnancy, let's say 5 weeks, 6 weeks, if there's been a difference in blood pressure between the 2 circulations of the twin on the right and the twin on the left, and you have a large AA anastomosis that is there, this baby, if its blood pressure falls, let's say, it sucks out blood from the other twin through this AA anastomosis. And once that suction is set in, it's like it keeps flowing by inertia. You've seen people sucking petrol out of petrol tanks with a tube. They suck it out and they just let it flow. So it keeps coming. You don't have to keep sucking it each time. So the same thing happens here. Because of the difference in pressure, there is a suction effect that happens from this twin side through the AA anastomosis. And then what happens is that this twin circulation becomes dependent or fed by this twin through the large AA anastomosis. So this baby, instead of getting pure blood from the placenta through the umbilical artery, through the umbilical vein, ends up getting impure blood from the other twin through the artery-to-artery anastomosis. And this impure blood is very deprived of oxygen, and therefore, if you do not have enough oxygen in the blood that comes into the baby, into a developing baby, that twin's morphogenesis is going to be disrupted, and the twin assumes monstrous shapes and sizes. It may not develop the upper part because whatever little oxygen here is extracted by the iliac vessels, and we know the iliac vessels go down to the limbs. So you often have well-developed limbs, but you don't have anything upstream because there's hardly any oxygen that reaches the upper story there. Therefore, you do not have a head, you do not have a heart. That's why a lot of these twins are called as acardiac twins, even though you can have several other forms with several fancy names as well. So this twin ends up pumping for both the circulation. So that gets called as a pump twin. This gets called as a perfused twin. And because it does not develop a heart in most cases, it's also called as the acardiac twin. So this is a very peculiar kind of AA anastomosis, which is why I said not all AA anastomosis play a protective role. But this AA anastomosis has to be in the substrate or setting of this peculiar placental angioarchitecture that I said to be effectively resulting in what we call as the trap sequence. So this is twin reversed arterial perfusion because the perfused twin is fed by reversal of blood flow from the other twin to the site rather than from the placenta. So that's about intertwin blood transfer and the problems it can cause. The other key thing about the placenta that we need to understand is territorial sharing. And as I said, this is dictated by where the two cords insert into the placenta. If the cords insert both into the center of the placenta or symmetrically at similar points in the placenta, this is called as a central-central connection, and therefore the placenta gets split equally and these twins grow along happily thereafter. However, instead of a central-central cord insertion, if you have one twin cord inserting into the margin of the placenta or worse still into the velamentous part of the membranes or the membranous part of the placenta, which is called as the velamentous insertion, then of course there's going to be a discordance in placental sharing, and this unequal placental sharing is what is responsible for growth restriction of the twin that gets a smaller share of the placenta. Now here again, if you have enough number of artery-to-artery anastomosis, they will play out a good balancing role, and there are placental studies that have clearly shown that if you have selective fetal growth restricted twins, more often than not, you would find artery-to-artery anastomosis in the surface. And greater the discordance of placental sharing, higher tends to be the number of artery-to-artery anastomosis. That's nature's way of taking care of both of these babies without letting them get into too much of trouble. So if you have a greater discordance, like say, for example, a velamentous versus a central cord insertion, you generally tend to have far more artery-to-artery protective anastomosis. Therefore, the imbalance is offset to a large degree. But despite that, if you do not have good number of AAs, then these twins could get into trouble. So the natural history of selective growth restriction depends not just on the cord insertions and not just on the territorial discordance, but it's also dictated to a large extent by the presence or absence of these protective anastomosis. If there are a good number of protective anastomosis, the severity and the phenotype is going to be less severe. If there aren't too many anastomosis, then you get the more severe types of SFGR, particularly the type 2 SFGR. So as I said, if the discordance in territorial sharing is not too much, or you have enough number of protective anastomosis that play the balancing out role, you tend to end up with the mildest form of SFGR, which is type 1. Whereas if at the other extreme, if you have very discordant territorial sharing and hardly any or very small protective AAs, then this ends up with a severe phenotype of type 2. Type 3, of course, all of us know is a very peculiar phenotype. It's by and large shares features of both type 1 and type 2, but the difference being you have one large artery-to-artery anastomosis. By large artery-to-artery anastomosis, I mean large by 4 times the diameter compared to a normal artery-to-artery anastomosis. Therefore, there's a large amount of blood that can be shunted from one side to the other side if there's a pressure differential. It's almost 16 times the blood that flows through a normal AA anastomosis. Therefore, this can lead to sudden intertwin transfusions or twin-to-twin acute transfusions, and that can lead to problems in one or both of these twins. So it's a very peculiar phenotype, which we call as type 3. And that happens, as I said, because there's a normal large artery-to-artery connection there. Now, that's about the theoretical aspect. The best way to look at some of these combinations and permutations is to do placental dye injection study, which is a very good learning exercise if you have to master your monochorionic placentae. Now, this was a dye injection that we did at the time of the last FIFA World Cup. So obviously, you have Portugal on the left and Argentina on the right. But there was no matchup between Portugal and Argentina for the World Cup, but this is because these were just my favorite teams, so I just matched up with these colors. And this is how you do a placental dye injection study. You get the placenta after delivery, wash them out clearly, wash out all the stains and the blood, and then you cannulate both the cords with maybe a feeding tube that you can get from your neonatal ICUs, and then push in poster colors or fabric colors through these, and then milk out the vessels so they come and completely fill up all the vessels, and do the same thing on the other side, and you can very clearly make out the anastomosis and the pattern of vessels there. So that's what we call as placental dye injection studies. This is, as I said, the best way to learn placental vascular anatomy and territory sharing. So let's look at a few case examples. But before I do that, let me just tell you what to look at once you've done a dye injection. Now, I've done a dye injection, imagine, on the placenta. The first thing I'd look for are the cord insertions. Okay, so here you have one cord that's inserting into the center of the placenta and the other cord that's inserting into the margin. So this is central versus marginal cord attachments, and therefore, obviously, the territorial sharing is going to be discordant. This twin, or twin 2, has far less territory of placenta than twin 1. And you can see from the vascular ramifications that twin 1 has got a much, much larger area of the placenta to feed it compared to the poor fellow sitting on the right there. So this is discordant cord insertion, so discordant territorial sharing. So the next thing that you would look for is to identify the vessels. Now remember, when you look at a dye injection study, or for that matter, when you look at it on the fetoscope, arteries always cross over the veins. So if I have to label arteries and veins in this particular placenta, for fetus 2, this would be the artery because the green crosses over the yellow, whereas this would be the vein. On this side, the blue would be the artery and the red would be the veins. Now, once you have labeled the arteries and veins, the next thing you would look for is the direction of branching. Now, if you're putting, for example, if you're looking at this particular vessel and you're not very sure whether this is a donor vessel or a recipient vessel, or does it belong to twin 1 or twin 2, what you need to do is to trace the vessel back and see which way it is branching or from which route it is branching. So when I reach this junction, I know this is branching from there, and I trace this back, I know this is a recipient vessel. The same thing can be repeated on the opposite side. So looking at the direction of branching and it in relation to the route of the cord, you should first, of course, have identified where the cords are inserting, and then from there, if you correlate that with the level or the direction of branching, you know whether that particular vessel belongs to the recipient cord or to the donor cord. And lastly, you start to identify all the meeting vessels of the anastomotic vessels, and sometimes dipping vessels that dip into the surface of the placenta may not seem to be anastomosing on the surface, but these are mostly the large arteriovenous anastomosis, where the connections happen deep inside the cotyledon and not on the chorionic surface or chorionic plate of the placenta. So that's how you read dye-injected placenta. And I'll show you a few case examples as well, that you get a fair idea of how it is done. So this is the first case. So as I said, the first thing I look for is the cord insertion site. So this is central versus, let's say, marginal bar elementals. You're not very sure because you can't see the membranes there. But anyways, discordant cord insertions. Obviously, as you would expect, there is discordance in territorial sharing as well when you look at the ramification. The next thing I start to look for is to try and identify my A's and B's. Now here, if you look at the green and yellow, very clearly at every point, the green crosses over the yellow. So the green is my artery and the yellow is the vein. So that's the artery there. This is the vein here. On the other side, if I see the blue crosses over the red, so blue is the artery and the red is the vein. So now I know my A's and B's, and then I start looking for connections. So here is artery to vein in this direction, another artery to vein in this direction, another artery to vein in this direction. So there are 4 artery to vein connections from twin 2 to twin 1, and only one artery to vein balance, or trying to fight it from twin 1 to twin 2. So there is very clearly a discordance in the number of arteriovenous anastomosis. There's clearly a net flow that's likely to happen from twin 2 to twin 1, with, of course, territorial discordance and placental sharing, or territorial sharing discordance between twin 2 and twin 1. And therefore, as expected, and there are hardly any AAs, if you can see. There is no place where a yellow connects to a blue. If you look carefully from one end to the other, there are no connections between yellow and blue, and therefore, yellow and green. Blue and green. There are no connections between the blues and the greens there, which means there are no artery-to-artery anastomosis sitting there. And therefore, that's why this set of twins developed TTTS with 37% discordance, with twin 2 or twin B being smaller than twin 1. Now, here's another case. You see a large unbalanced AV anastomosis. It seems to be the only anastomosis sitting there. So this red is artery, this purple is vein. So there is an artery to vein connection from the right to the left. There's nothing else that seems to connect here. So there's no balancing anastomosis here. So you would think that there is a unbalanced AVs and this would develop TTTS, but lo and behold, if you look carefully, sometimes you might miss these peripheral vessels. So if you turn this placenta around and see there's a large artery-to-artery anastomosis there. The same color tells you that this is the same artery-to-artery type of anastomosis. And this is what prevented TTTS in this particular case. So that's how we said the AAAs are protective anastomosis more often than not. Now here's the third case. Cord insertions again are discordant. One is at the margin and the other is in the center. Here my green is artery and the orange is vein. On the other side, blue would be the artery and the red would be the vein. Now I need to look for anastomosis. There are very tiny anastomosis there. I really need to zoom up this placenta to show you those. And you can see there's a connection here. There's a connection there between the blue and the yellow. There's a small tiny connection somewhere in the depth there as well. This is the blue that connects to a yellow here. So these are tiny peripheral artery to vein anastomosis, unbalanced because there are 2 from left to right, but only 1 from right to left. And therefore, as I said earlier, this would result in twin anemia polycythemia sequence. This is the fourth case. Here you see this very peculiar angioarchitecture that I spoke to you about. The cord insertions are almost kissing each other. There's hardly any space between the 2 cord insertions, shown by the 2 different colored stars. And if you look very carefully, this is an artery. The green is an artery because it crosses over the red. This side, you've used the same colors, and this again is an artery there. And you can see a very clear, big connection between the 2 arteries, which is what we call an artery-to-artery anastomosis. So cords very close to each other, a large artery-to-artery anastomosis. And if you look carefully, there's this one umbilical artery here, whereas this one, believe me, had 2 arteries. So this is single umbilical artery on one side, a 3-vessel cord on the other, cords kissing each other, large artery-to-artery anastomosis between them, and this results in the trap sequence. A fifth case, again, you can see cord insertions are not central, but they are symmetric. Both are marginal cord insertions. And if you look at the territory at one glance, the territorial sharing is pretty much even. So that way, we're not really concerned about growth restriction in these twins. But then let's look at the A's and the V's there. Green crossing over yellow is A. So green crossing over the yellow becomes the artery and the yellow becomes the vein. On the other side, it's the blue that's the artery and the red that's the vein. And now we look for connections there. There is an AV there, that's the star there. There's another, there is an AV here that's balancing out this fellow, AA here, and there's another AA here that balances that out. So one
recording in progress.
A bluish gray versus a grayish tells you that this is an artery-to-artery anastomosis.